Again, thank you so much to all the attendees. We're really excited to see you here today for our webinar on promoting mental health in congenital heart patients and looking at it in global perspectives. So the first presenter I'm very pleased to present is Dr. Leila Ladek. She is an associate professor of nursing at Aga Khan University in Pakistan. She's also the Global Health Chair at the International Society of Adult Congenital Heart Disease. And she's published numerous publications, I will note, on congenital heart disease, including one of the first studies of well-being in adult congenital heart patients in Pakistan. So, Dr. Leila, please begin.
Thank you so much, Emmy. Am I audible? Okay.
Yes, you are.
So first of all, many congratulations to Global Arch for providing us this platform and arranging and organizing this webinar, a very well needed webinar to address the mental health needs of adult congenital heart disease patients from a global perspective. So I have nothing to disclose. So when we talk about congenital heart disease, it's a chronic disease, it's a lifelong disease, and it affects an individual from the point where that infant is conceived to different stages of the life, including infancy, adolescent, adulthood, elderly, etc. And there are different issues which an individual with congenital heart disease, so during the antenatal phase, the physiological compromise because of the CHD impacts the brain and neurodevelopment of that infant, followed by different surgical procedures that an individual or the infant goes through, the hospitalization, and then when that person enters into the adolescent phase, the physiological changes, the puberty changes that individual goes through, followed by a lot of societal expectations, employment, etc., etc. In addition to that, a lot of social determinants of health actually impacts the overall quality of life, which includes the physical, mental, social well-being of an individual, which overall impacts the quality of life and the productivity of that individual. So the social determinants of health includes the socio-demographics, gender, and socioeconomic status, education, as well as availability of the resources with regards to the healthcare facilities available to that individual. So these are some of the papers that I was able to find that focused on the anxiety, exploring anxiety and depression in adults with congenital heart disease. And these are just the glimpses of some of the papers that I was able to find. Unfortunately, I was hardly able to find many papers, or rather very few papers from LMIC. The majority of these papers that I found were from high-income countries. So this is a study recently published where a 10-year review was done in the state of Texas for the hospitalized patients, and what was the prevalence of the mental health disorders in these individuals when they got discharged from the hospital. So about 12.1%, about 12% of these patients had at least one mental health disorder at the time of discharge from the hospital. In addition, anxiety and depression were the most prevalent mental health issues which these patients had. And apart from that, you can see that there were other mental health disorders. This is a recent review where different studies have been reported, and they were part of this review. This review reports that the adult congenital heart disease patients had high prevalence of anxiety as well as depression. And you can see that anxiety of as high as 45% or over 45%, and depression of as high as close to 35%. And these numbers are significantly high compared to what they compared with the reference population, or we call as a healthy population. You can see these dotted lines are for anxiety and depression reference points, and these are significantly high in adult congenital heart disease compared to the normal population. Moreover, this review also reports the lifetime prevalence of depression and anxiety. And this is very evident that ACHD patients have lifetime prevalence of depression and anxiety in about 55% for the anxiety and about 40%, 43, 44% for depression cases. And this is very, very high. Now, there can be multiple reasons for that. As I mentioned in my previous slides, that the clinical factors, social determinants of health, a lot of these factors play its role. Some of the theories have also been reported, which could lead to the high prevalence of depression, anxiety, and other mental health disorders in ACHD. And one theory is the detachment theory. So because CHD is a lifelong chronic disease, so infants, when they undergo different surgical procedures, depending on, of course, the complexity of CHD, and when they are detached from their parents, from the mother especially, how does it impact the psychosocial and the psychological health of those infants, not just at the infancy level, but also in the long run? So these are some of the factors that we need to consider. And today, when we will be talking about ACHD, it's actually, we are also talking about some of the strategies that we need to address at the earlier stage, so that a lot of these mental health issues are addressed at an earlier stage. This is one of the papers published from Approach IS, where 15 countries participated. And unfortunately, there was only one country, that is India, which was LMIC. So this paper also reports that there was a large effect size with regards to mental component summary in these individuals. So that it was, this data is of about 3,500 patients or over. So patients with cyanotic heart disease, univentricular disease, Eisenmenger syndrome, and other CHD diagnosis had a large effect when compared to the normal controls. And though we do not have published data of Eisenmenger and these complications and these syndromes from LMIC, but assuming that there's a late diagnosis, late management because of the resource constraints, etc., we do see patients with Eisenmenger syndrome in LMIC. I'm talking about Pakistan, and I'm sure it must be similar case in other LMIC as well. So we can infer that what would be the situation of mental health in a lot of LMICs. Just like COVID hit normal healthy population, it also hit congenital heart disease, adult CHD, particularly the psychological and the psychosocial domains. So you can see that the depression and anxiety was significantly high during the peak time of COVID, though it got a little bit decreased here for the anxiety in December and January when we all got acquainted. But with regards to depression, it actually increased during the second phase or second wave of COVID-19. And as we all understand that though COVID-19 is pandemic, we may be over with that, but the mental health pandemic due to COVID-19 will still be there for many, many years. And when we talk about ACHD, I think we need to be mindful to address this. Unfortunately, the disease burden of congenital heart disease is in areas where we have less resources. And you can see here that children versus adults. So still in Southeast Asia, Asian countries, we have more children compared to adult. But this picture is, with the passage of time, it is changing. So we are also just like high income countries where we have more adult population because of the advancement in the technology and management and the surgical procedures, etc. We will also have similar situation in LMICs and upper middle income countries as well. So this is one of the studies that we did on ACHD. This was a mixed method study. So the interesting findings from this study, apart from that, the quality of life was poor in adults with congenital heart disease. So the most affected domain within the quality of life was emotional and the psychosocial domain. And a lot of socio-cultural factors, because this was a mixed method study, so the qualitative arm of the study actually complemented and gave us the opportunity to understand what are the reasons for this poor quality of life in this patient population. So some of the factors that were highlighted included gender. So for instance, females had poor quality of life, and because Pakistan is a patriarchal society where males are given more priority, and in the scenario when we do not have universal health coverage, people have to pay from the pocket, and these surgical procedures are quite expensive. There was a biases with regards to the diagnosis, with regards to the provision of surgical procedure and other interventions, etc. Similarly, marriability, marriage, conception was highlighted by majority of the participants, and some of the female participants who were diagnosed after the delivery. So some of them even had were diagnosed during their second pregnancy or second delivery. So they considered this as a blessing, because otherwise they thought that nobody would be willing to marry them, and marriage was, the priority for them. And of course, for males, the financial support that they had to provide as part of the societal responsibility, and a lot of family responsibilities and commitments that they had to offer to be a productive and contributing member of the society, were some of the issues highlighted. And of course, employability was one of the major issues. Keeping in mind a lot of the issues related to mental health and related to the overall well-being of ACHD, so we do have the standard sets developed by ICHOM, International Consortium of Health Outcome Measures. They've also highlighted mental health and the social health, physical health, and the overall health. And these standard sets are available, and we are, as part of one of the PhD students project, we are testing the validity and feasibility of the study in Pakistan. So one of the issues, and this is not just specific to these standard sets, but a lot of the standard sets and the guidelines available is like the questionnaires that are being recommended. They are mostly in English. And I think this is one of the major barriers that we would face with regards to using and utilizing and implementing these standard sets in our setting. Since in Pakistan, and there are so many other countries where local language is different than English. So one of the issues that we are struggling with is translating these questionnaires, getting them piloted, following the whole process of translation, etc. So this is one of the major issues when we are doing research in an LMIC like Pakistan. With regards to Approach IS, so we look forward to, because for Approach IS 2, Pakistan is also part of this consortium. And we look forward to that we have a good representation of countries, LMICs, who are part of Approach IS 2. So we're looking forward to 15,000 plus data. And inshallah, we will see the results of these Approach IS 2 from LMIC, high income countries as well. And we will get an understanding of the issues these patients are facing in these countries.
Thank you, Dr. Ladek.
Sorry.
That was, go ahead.
So these are the references. Thank you.
That was an excellent presentation. I really appreciate that. I wanted to just explain that we will have time at the end to ask questions. So make sure that you write down your questions. You're also welcome to type them in the box now, but we're going to take all the questions at the end. So our next presenter is Dr. Adrienne Kovacs. She's a psychologist who has worked in this field for many, many years, and I'm sure you noticed her name popping up in a lot of the previous slides. But what she's going to focus on today is she's a co-author of the American Heart Association paper on psychological outcomes and interventions for individuals with congenital heart disease, which is an interesting paper, as she'll explain, because it isn't just about what the problems are, but setting a standard for what people should do. I should also note that Tracy Levesque, Ms. Tracy Levesque, who's here, I believe, was also a co-author on this. So Adrienne, please begin. And I think you're on mute.
You'd think by now, did it? Can you hear me now?
Yes, we can hear you fine.
Okay. You think, almost 3 years into Zooming, I'd have it down. It's really an honor to be here today. Thank you so much for the invitation. And I'm speaking on, isn't this going here? There we go. I'm speaking on behalf of a really wonderful group of co-authors here. So you can see, we're just thrilled that earlier this year, we released our AHA scientific statement, Psychological Outcomes and Interventions for Individuals with Congenital Heart Disease. And I do highlight that this is a scientific statement from the American Heart Association. So You know, a lot of what I talk about, maybe we'll have a somewhat of a focus on the US, but we do have a global perspective as well. And I'm so grateful to this incredible team of co-authors. Tracy was one of them. And I think this is what we're really proud of. So our authors included pediatric and adult psychologists, pediatric and adult psychiatrists, a licensed clinical social worker, pediatric and adult congenital cardiologists, and a nurse practitioner. And our authorship team included 2 individuals with congenital heart disease. So we're pleased with the diversity of the clinical expertise from our team. And just briefly here, when I think about trying to understand what we talk about mental health, I do like the World Health Organization's definition. And I just wanted to kind of set the stage with this. They define mental health as a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. It is more than the absence of mental disorders. It exists on a continuum, which is experienced differently from one person to the next, with varying degrees of difficulty and distress, and potentially very different social and clinical outcomes. And it is defined as a basic human right. And so I think this theme carries across all of the countries. And I like to emphasize that mental health is absolutely a subjective experience. There are many factors that can influence mental health and psychological well-being across the lifespan, and no 2 patients have the same experiences, which is why we say things like people with congenital heart disease are at elevated risk. We say that there's a higher prevalence. We can never actually define what any individual patient is experiencing. If we want to know how somebody's doing, we need to ask them directly. And Dr. Leduc shared this figure earlier, but we know that people born with congenital heart disease are at risk of potential stressors and challenges across the lifespan, and actually even beginning in the prenatal period. You know, as infants, there are stressors in the ICU. There are both adverse and benevolent childhood events. We know that things like neurodevelopment, emotional regulation, brain injury, we know that there's a relationship between neurodevelopmental outcomes and psychological well-being. As children grow, there are factors related to their family life, identity formation, going to school, interacting with peers. As they move to adulthood, they may face subsequent medical interventions. They are working, maybe developing families of their own. And as they get older, there are concerns related to aging and mortality. So again, no 2 patients are alike, but these are some of the challenges that they may face across the lifespan. And here's why this matters. We know that mental health doesn't only affect psychological well-being, it can also affect our physical health. So it affects our ability to be adherent with treatment recommendations. We know in the general population with acquired heart disease, as well as congenital heart disease, that psychological factors are associated with morbidity and mortality. So people who are depressed and anxious are more likely to have comorbid conditions and to have earlier mortality. It can certainly affect social health and quality of life. And there are also implications for the healthcare system and society at large. Looking at the pediatric population here, and I realize I won't have included every country, but these are the ones that I could easily locate studies for. If we think of, gosh, US, Germany, the UK, Belgium, Switzerland, Netherlands, France, Sweden, when we look at some of these studies, internalizing behavior difficulties. And so these are things like depression and anxiety, affect about 1 in 4 of children with congenital heart disease. And externalizing behavior difficulties, these are things that we observe and interact with others, things like defiance and oppositional behaviors, affect 15% of children with congenital heart disease. However, the lifetime prevalence of any psychiatric disorder may be as high as 65% among adolescents with single ventricle congenital heart disease. So from these collective studies, we know that children and adolescents with congenital heart disease do have an increased risk for significant psychological difficulties. Turning to the adult population, so some similar studies here. So we have US, Germany, the UK, France, Netherlands, Canada, we have Czech Republic, Greece, Iran, and Korea here. When we look at self-report studies, the rate of elevated depressive symptoms ranges quite widely from 6 to 42%, and the range of elevated anxiety symptoms is from 34 to 42%. That observation of increased risk of or anxiety being more common than depression is actually, I've observed that in my own clinical practice as well. So although we tend to focus on depression, I think that anxiety is much more prevalent in our patient population. When we look at clinical interviews, I like to think that I round off to about a third meet current diagnostic criteria for a mood or anxiety disorder, with a lifetime prevalence of around 50%. And I like to emphasize that the exception to this collective literature really is the Netherlands, and research, particularly from the groups of Elizabeth Utens, suggests that their adults with congenital heart disease in Netherlands tend to do quite well, and that their psychological outcomes are similar or sometimes better than that of the general population. And unfortunately, few people from these studies who meet diagnostic criteria for a mood or anxiety disorder actually receive any kind of mental health treatment. Dr. Ledak introduced this study earlier, Approach-IS, and this stands for Assessment of Patterns of Patient-Reported Outcomes in Adults with Congenital Heart Disease, an international study. And in phase 1, we enrolled over 4,000 participants, and they completed several patient-reported outcomes, including the Hospital Anxiety and Depression Scale. And this produces 2 subscales with total scores ranging from 0 to 21. And we had patients from 16 countries, and we see them listed here. We can see the average anxiety score and the mean anxiety and depression scores. Again, these range from 0 to 21. So we can see that in general, anxiety scores were a bit higher. The average score did fall below a clinical threshold of 8. We can see that there was variation between some of the countries, and as mentioned earlier, the only country, middle and lower income country, was India, and they actually had the highest scores on both anxiety and depression subscales of the HADS. And so one of the things we wanted to do with our scientific statement was really advocate for the integration of mental health care within CHD teams. And I realize that this is more realistic in some countries rather than others, but just to let everyone know, it certainly is not done widely in the US or within North America. And we, as a group, we have 2 perspectives. So one of our goals really is to increase the psychological competence of all team members so that everybody on the team, physicians, nurses, NPs, PAs, all feel better, more empowered to discuss psychological issues and to support the psychological well-being of patients under their care. At the same time, we feel really strongly that the time is now to integrate mental health care, psychologists, psychiatrists, counselors, licensed clinical social workers, to embed them within CHD teams. And here are the reasons we identified. We think it's really important to provide timely provision of psychological care that is grounded within an understanding of congenital heart disease. We recognize that it can provide greater opportunities to offer care regardless of socioeconomic status. There certainly is superior interdisciplinary care coordination. So these really are advantages for the patients themselves listed on the left. And then if we turn to the right, if we focus on what some advantages are for the other team members, well, having a mental health professional embedded within the team can create or increase the awareness and skills-based training for all members of the team about important psychological and social factors. It means that they have increased confidence in initiating discussions of psychological well-being. So they feel more comfortable actually raising this issue during clinical visits, knowing that they have somebody who they can refer patients. And finally, this can contribute to interdisciplinary quality improvement initiatives and research collaboration. So in conclusion, we really hope that our scientific statement will spur teams who don't already have mental health professionals as part of their team to do so in the very near future. Thank you.
Thank you so much. Dr. Kovacs, that was excellent presentation. I did want to note, somebody asked me in chat, these slides will be available online. And in fact, you will be able to watch the whole webinar on video. I wanted to introduce the next two presenters. They're going to be co-presenting. One is Dr. Liza Morton, who's a psychologist and also a person living with congenital heart disease. And then Tracy Levecki, who is a social worker who also treats patients with mental, sort of psychological challenges. And the two of them are an author of a new book called Healing Hearts and Minds. And the goal of the book is to take a really global, overarching perspective and give people tools to manage their challenges. So I'm very pleased to have them presenting today.
Thank you, Amy. Can you hear me okay?
Yes, we can hear you fine.
Okay, thank you. Thank you so much for inviting us to be here today. It is an honor to be able to talk to you about our book. This is just a little bit of an introduction to, you can see the book is there and it's currently available for pre-order and will be published on the 13th of January. So just to introduce myself and Tracy. So I guess we're kind of dual experts in that we are both mental health professionals, but we both are kind of first generation pioneering patients who both have quite complex congenital heart conditions. And we will introduce ourselves kind of separately. So on the left, you can see that's a picture of me as a baby. That's the first picture that my mum had of me out of the hospital when I was about 6 weeks old. By that stage, I had had 2 thoracotomies. So I guess you know what that is. The ribs being split and a pacemaker fitted, and a stroke between those 2 thoracotomies. And that was because I was fitted with a cardiac pacemaker in 1978, and that was a world first at the time. And that's because I have complete heart blocks, so they basically had to do that or I wouldn't have survived. So I think I look like a kind of scrunched up, poorly little baby that's kind of been through quite a lot there. But my mum tells me that she loved me better. And Tracy will kind of tell you about her own story there. So since then, and I guess lifelong, I have always felt a lack of support for the psychological and emotional impact of living with a truly lifelong condition. And part of my journey to become a counselling psychologist was motivated by that awareness of that need. So currently I am a counselling psychologist in independent practice. I did used to work for the NHS. I also have a PhD by research, and I've always kind of been involved in research as well. So I also part-time have a lectureship at Glasgow Caledonian University at the moment. And I sit on the management board of the Somerville Heart Foundation, which is the leading charity for people with adults with congenital heart conditions in the UK. I've also been involved in the development of healthcare standards in Scotland, because health has devolved in Scotland, and following several life-threatening incidents with my own care, I submitted a petition to our Scottish Parliament asking for those standards. And over the last 10 years, I've been on various health committees and health boards to that end. So yeah, that little baby kind of, I guess, from birth has been dependent on just countless interventions. I can't tell you how many times I've been in and out of hospital, and it's been very uncertain. Accessing care has at times been incredibly challenging, especially during adulthood, but it's also been quite isolating because my experiences have been so different from my heart healthy peers. So I was very aware of that from a young age and looked towards addressing that and having that met. I met Tracy online, so Tracy will introduce herself.
Hello, everyone. I am honored to be here. Thank you so much for the invitation. So the pictures on the right, that is me after coming home from the hospital and my grandparents surprising me with this collection of stuffed animals. I was born with transposition of the great arteries, and this was after coming home after a very long hospitalization, having had the mustard procedure. Since that time, I have had, I honestly have lost count of how many hospitalizations I've had. I do have a pacemaker from the age of 12 and have had several ablations. I found myself going into the helping profession and became a clinical social worker. And because of my experience as a patient, I remember being so frustrated, saying, "Where is the support? Please stop offering me anxiety medication and send someone to talk to me." And after requesting that for a few days, they finally looked at me and said, "Well, maybe you're that person." After I came out of the hospital. And that was the development of this specialty of mine. And I have been working now with other congenital heart individuals with congenital heart conditions, probably now since around 2006. Through UCLA at first, and now through the Adult Congenital Heart Association. I've helped them to put together a peer mentorship program, which is up and running now for over about probably 12 years or so, and I'm still consulting with them and helping to supervise that program. And that's a little bit about me. So I'll take this slide. Basically, our book is the book that Lisa and I have always been looking for, but we could never find. I remember scouring bookstores and, back in the 80s and 90s, and there was nothing out there for anyone like me, which was very isolating. And I felt very different. And, I said, something's got to give here. So we were brought together through our research or Lisa's research and my advocacy. And we both looked at each other's book outlines and they were almost identical. So really this book is the first of its kind ever to focus on any kind of the elevated risk of psychological and emotional challenges and social. We worked so hard to bring in voices from all over the world. We have testimonials. I don't even know how many we have at this point, but we were able to get many from, of course, the US and UK, but Netherlands and South Africa and Malaysia, Australia, New Zealand. We really wanted to get a diverse representation because no two individuals are alike. We all have different lived experiences, and we also provide a lot of different evidence-based strategies for coping with these psychosocial issues. We wanted to let people know that CHD is a lifelong issue, because the Adult Congenital Heart Association estimates that 90% of us are not in specialized care. So that's important also. That's a message that we make clear in our book. We have an entire section focused on for families and healthcare providers, educating them about the best way to support us. And for physicians and healthcare providers in the ACHD team, how to promote psychological awareness in care. And most importantly, we wanted to just let people know they weren't alone. We're trying to offer hope, connection. We have a whole section on resources that people can tap into to get more support. And we want to let people know that it is possible to thrive despite their CHD. Throughout the book, we also acknowledge several times that we know no two people are alike. Everybody is going to experience their CHD differently, and not everybody will experience everything we have in the book. Everyone's story is unique. Lisa, I'll hand it over to you now.
Thanks, Tracy. So just to give you a little bit of a sneak preview of the contents. So as Tracy had said, we worked really hard to develop something that was very accessible to everybody, but that's also grounded in the most recent evidence-based practice and psychological theories. And we wanted to we aim to validate a normal response to abnormal life events. So what we've done is, first of all, we kind of start with a brief medical history, because we wanted to tell our collective story as this medically new population. we all know that survival rates have increased enormously over the last kind of 50, 60 years. So it's quite unusual to live with a heart condition from birth through adulthood through to the end of life, but also being dependent on medical treatment. So we wanted to consider that and to look at our collective story so that we could see it within that quite novel context, and then think about, well, what is the possible consequences of that? As I said earlier, I think a lot of the kind of issues that we have are because when we go through life and we face adversities, usually our peer group is going through those same kind of challenges and we can talk to each other. Whereas I can remember having, quite serious cardiac surgery in York Hill Hospital, and 2 weeks later being back at primary school and having no words to share that experience with the other children around me. And in fact, just not even trying to, because I knew I would just evoke horror or pity. So it can be quite isolating. So what we wanted to do is promote this sense of connection and validation, really, of kind of what we endure. And so people can understand their own lived experience. And our aim there is to validate that kind of those normal responses so that we can actually prevent and mitigate any more adverse or serious mental health problems occurring in the kind of eventually. Because I guess it's about thinking that a lot of the time the prevalence rates for anxiety and depression are potentially so high because of this unmet need in terms of being able to process these difficulties, for them being acknowledged and having that space. And particularly because when you have a congenital heart condition, very often there's this kind of social expectation to be brave, to be a heart warrior, to be that you're special. And a lot of people don't really want to talk about the more difficult side of things because they don't want to burden their family further, or they don't want to appear ungrateful. So all of these things can create this almost veil of silence, and that we don't really talk about the kind of the more difficult side of things. And when that's bottled up and those layers of trauma occur, then that's, I think, when more serious mental health problems can arise. So what we've aimed to do is, well, absolutely, as Tracy said, validating that every one of us has a very unique experience, and even generationally, people born in the 70s, 80s, 90s have a very different experience culturally as well, and in terms of the care they've received, and obviously in terms of personal attributes, social support available, medical support. There are some common themes that we wanted to cover just so people don't feel alone. So we talk about that in terms of the possible impacts. We then go on to looking at the body's alarm system. So we talk about anxiety and trauma, and how when we are raised in a more hostile environment, we now know from psychology that it means that our kind of window of tolerance for feeling safe can become narrower. And in terms of my own research, that kind of feeling safe is something that I'm very interested in, and how we can widen that as well therapeutically, which we know that we can. We then talk about kind of feelings like anxiety, shame, anger. We try to normalize a lot of them in terms of normal response to injustice, the unfairness of the situation, and again, those kind of layers of trauma and loss. We talk a lot about the different kind of losses, loss of a normal childhood, for some, loss of the ability to have children. But then we kind of shift gear a bit and we try to empower people with, okay, what can we do about this? What do we know now from the most recent psychological evidence base that we can use to support this journey? Because there's loads of information out there. So we talk about kind of basic self-care, having a what we call a stress management toolkit that we can draw on to deal with these additional adversities. And then we move on to how to manage uncomfortable feelings. I think there's quite a lot of messaging where people are when you have a heart condition, you kind of suppress feelings, and often that's necessary at the time because we know that for survival, sometimes we just have to get through it. But then afterwards, how do we manage those feelings? What do we do with them? How do we adapt kind of healthy coping strategies there? We then talk about unhelpful thoughts and behaviours. So that kind of can go more into maybe kind of core beliefs or thoughts that we've developed, and they can be health beliefs, or they can be ones about our identity, or kind of where we fit socially. And then we speak about important relationships. We start off with our relationship with ourselves, because often there can be a kind of almost fight with our body. Often people with congenital heart conditions try to mask symptoms and try to, because it's an invisible condition, function normally for fear of discrimination. So it's kind of trying to find a good relationship with yourself. And then we move on to how that can impact on other important relationships, such as our parents, children, our peer group, our colleagues. So we kind of try to cover all of that. We then have a chapter where we go quite specifically into coping with medical procedures, events and symptoms. It's quite unusual in life for people to face a traumatic event and the knowledge that they have before and that they will again. You know, if somebody has a traumatic incident, usually it's kind of a one-off, or by the time they come to therapy, you know, there's a good chance it's not going to happen again. But we have to kind of go through these events knowing that they will be repeated. So we kind of move on from that to taking the wheel. So that's all about empowerment. It's about self-management of a long-term condition and really getting people to think about that. And then we have a chapter on post-traumatic growth. So the gifts of CHCs, kind of acknowledging that, you know, there are gifts. Often we're more determined, or we have a greater appreciation of meaningful relationships. It lets us kind of hone in on the fragility of life, but also how precious it is. And our final chapter, as Tracy had mentioned, is about supporting people with CHC. So we really hope this book will be read far outside just people with lived experience. We want everybody to read it. We hope that the book itself becomes an advocate, and we kind of see the whole CHC population. I mean, this is a public health crisis, really, when you think about the lack of awareness and the lack of support. So we've included in there kind of recommendations for healthcare providers, but also for psychologists as well. We've then just included as many useful organisations and resources as possible. So there's just a couple of slides here that I'll let you read yourself, but these are just some of the quotes that Tracy mentioned. We've drawn on, I mean, I'm not sure, but I think it must be close to or over 50, I think, Tracy.
I think so.
Yeah, quotes from people, and we were so delighted to have so many people engage with this, but we also felt it demonstrated just the need. So these are people with lived experience, and obviously there's a variety there, but they've said things like, recently I've been fighting breast cancer. At every turn you get offered psychological help, yet in my 42 years I've never been offered that in relation to heart disease. I think you will get a copy of these slides, so you'll have more time to kind of read these. But we also included this one because these are just to demonstrate that we've not just included quotes from people with the lived experience, but we have tried to include parents, sisters, partners, cardiologists, healthcare providers, psychologists, just so that we've got that whole kind of global community and our whole kind of CHD family pulled together. So I'll stop there, and we are happy to take questions if there's time or at the end.
Thank you, Tracy and Liza. That was really extraordinary. So if you can stop sharing your slides, that would be fabulous, so we can see everybody. And I should note that we've got lots of comments, and most of them just saying how helpful this book will be. There is one question I just want to ask quickly, which is, are there any plans to get it translated? Or is that your goal?
Yes, that is our goal. We have asked our publisher, Oxford University Press, and they assured us that they're going to be pitching different publishers all around the world. So our fingers are crossed that that will happen. Usually that doesn't happen, he said, until after publication. Right. So it might be a beat, wait a beat, but
he did also say that they have to see a demand from the country. So if anybody wants to kind of advocate from that perspective, if they can see that there is the demand there, they're more likely to do that.
Right.
Great. So before we start with our questions from the audience, I wanted to just ask some of our presenters just one follow-up question. But first, I wanted to introduce Grace Gerald, who you didn't hear from as a presenter, but we wanted to make sure that we would have somebody on our panel discussion that was having lived experience of congenital heart disease from a lower middle income countries. So Grace is from Malaysia. She started the first congenital heart disease group in Malaysia, which does include adults like her, although they're still rare in Malaysia. And I wanted to start out with you, Grace. You know, you've listened to this, obviously lots of information. And just talk to me a little about how, you know, in medicine, we talk a lot about feasibility, applicability, you know, like how possible do you think this would be to implement? And what would the barriers be in your culture? And how, from your perspective, how do you see this as useful, not useful?
Okay.
How do you see
I
the challenges as different?
Yeah, thanks, Amy. I think in my culture, mental health is a very developing topic. Um, when I was a kid, there was no such talk. I didn't have a support group. I didn't have psychological um, anything for that matter. I went to the doctors for just the health part. No one really asked how I was doing, and so. But years later, I think currently it's still in the stages of development, but I think it is still a bit of a taboo subject because the whole discussion of, you know, you're sick, you have a congenital heart condition, it's not something that everybody talks about. There's a bit of taboo, there's a bit of shame associated with it. So it's not that, you know, everybody's rallying together. It's like, yes, I have this condition. You know, so it's just a bit hard even to find other people with this condition. Like the parents talk about it more, and the kids. So if they are a parent with a kid with congenital heart, they actually are more open, but it's a bit more rarer to find adults with congenital hearts. I personally know only about 10. I'm sure there are many out there. Yeah.
Great. Thank you, Grace. And I wanted to then turn to Dr. Ladek. I know that one of the reports we have, both from your group and from the groups we have, starting in many countries, is that stigma is a huge barrier for people to getting together. And it's not just a psychological or cultural issue, it's a fear of discrimination. So I was just wondering if you wanted to comment on that, Leila.
Yeah, sure. So I think stigma, and I completely agree with you, Amy, that stigma is, I think, a global issue specific to a lot of chronic diseases, and in particularly this congenital heart disease. But I think with regards to the acceptability of CHD patient population in LMIC is, you know, we face a lot of issues because of health literacy, because people do not have awareness about CHD. And in my study also, I found that some of the people had actually, the society has, you know, understanding that it's a contagious disease, for instance, and they would not let let their children play with somebody who is CHD. Or maybe, you know, the females, they shared that they were stigmatized for the surgical scar that they had. And parents, it was very difficult for the parents to take the decision, you know, going to survive their child with CHD, with the surgical scar, versus, you know, let the child go, because nobody would marry. So one of the mothers, I still remember her words, and she shared that the family was, even her husband was not in favor of getting her daughter operated for CHD, and she had complex CHD. So she went through multiple operations. And the debate was going for surgery, going for surgical scar. People would accept her as an individual, and then, you know, marriage, etc. And then apart from that, the one of the major decision making indicator was the finances. So is it worth spending that much of money on a female child versus, you know, saving a boy with who would still have, you know, investing on a boy with the same cost versus saving a girl. So no, these were a lot of socio-cultural issues and stigma that was related to that. You know, so it's very difficult. And when we talk about mental health, and when Grace was sharing her experience of how things have evolved, and, you know, how things are getting better. So I think in Pakistan also, the acceptability to mental health, seeking mental health help, uh, we still have a lot of stigma attached to it. There's a lot of reservations. It's still a taboo. But I think things have improved, but it's, you know, it's a long way to go.
Great. Thank you so much. Adrian, I I noted that you said that in the US and in Canada, I know the struggles that we've had to get people actually to get their psychologists. And I did want to note that many of you may be aware that the Adult Congenital Heart Association implemented quality standards, and we, under my leadership, because I ran that organization for a number of years, at the meeting where we were setting those standards, the only time I had to assert my authority at that meeting, right, was these wonderful clinicians, our medical advisory board members, literally said, we can't mandate a half-time social worker or psychologist because of, nobody can do that because of constraints, right? And it may be different now, and that's one of my questions, but, and I literally had to say the number one problem our members tell us about are these problems, and this is unacceptable. This is how you change things, through quality improvement, through making it a quality standard. So Adrian, I wanted to circle back about that to you, is that was probably about 15 years ago. What have we seen in improvement in investment in the US and Canada? Because I know you have both those perspectives.
Yeah. Do you know, I've been working in congenital heart disease for almost 20 years, and I think that gives me the ability to be a little feisty when it comes to this topic, because I'm not new to this. And I actually feel really strongly that actually accreditation criteria, actually, that is absolutely the place where we ought to have mandated a requirement for inclusion of mental health professionals. So right now, a program needs to have a half-time social worker. And what that meant is a lot of programs who didn't have social work before now have it, which is wonderful. And it means they need to have access or a referral pathway for a mental health professional, but it doesn't necessarily need to be embedded within. And I think actually, when we say it'd be nice to have, nobody does things when we say it'd be nice to have it. But when we say this is an essential component, people figure out a way to make it happen. And I think that's especially true in the US, where psychologists can actually bill for their services. It's different in Canada, where I'm back in Canada, we can't right now. So I feel that if we want to move things forward, we need to make that change happen. And one of the things our entire authorship team felt really strongly about is it's time to go beyond awareness to actual implementation. So, there are a lot of people who publish studies and give presentations and talk about this, and will write a paper saying, oh, we need to screen and we need to do this, but that hasn't really translated into widespread implementation of clinical care focused on this. I will say that there are a few programs that are moving in that direction. So I tweeted something yesterday and a program replied, and they said, we do this now. We focus on psychological care at our CHD clinic visits. So I will say the needle is moving forward very, very slowly. And I think we need to do everything we can. And that was a goal of our statement, to say this needs to happen now. So I am absolutely a strong advocate. People figure out a way to make it happen. We can choose where we spend our philanthropic dollars as well.
Thank you. That's very, it's great. And hopefully, I know how powerful the kick can be from guidelines.
Yeah.
And I wanted to ask Liza, I'm just curious, what is the situation in the NHS? Is it mandated? Is it prioritized? Because you have a very different healthcare system.
Yes, we do. So within the UK, Scotland has in fact devolved as well. So Scotland has its own healthcare system. We have our own parliament, so certain issues are devolved. So that was what I had mentioned. I had a series of life-threatening incidents. And when I say life-threatening, I mean they were life-threatening, where I couldn't access the care I needed when my pacemaker had broken, which was really quite scary. But anyway, that had culminated in me listing everything that happened, and I fed that back to the NHS. And it, much like what kind of happened with Tracy, it was kind of put back on me that we don't have a strong advocate in Scotland. So we don't have standards, but you're going to have to be the one that gets them, because we're accused of empire building. So I took a petition to the Scottish Parliament, and over the last 10 years, I've worked really hard. And I worked a lot with Michael Cumper, who we sadly lost a couple of months ago. Michael saw me on the BBC News and he contacted me and he asked me to continue my work under the Somerville Heart Foundation, because he was basically doing that down south. So he said, if you do it in Scotland, we can team up. And he was hugely influential and will be incredibly missed. So England has standards and has had for quite a long while. In Scotland, we now have national healthcare standards for the national service, and I was very adamant, like yourself, from the start about there being a psychologist in there, and that did meet with quite a bit of resistance, but I was delighted to hear at the beginning of this year, for the first time, we have a psychologist at the specialist service, which is amazing. But we are still working, 10 years down the line, we are still working on local healthcare standards, which is incredibly frustrating, because our care is kind of split between the specialist centre, but then some stuff's provided locally, and actually a lot of the problems happen locally because the specialist centre doesn't have emergency care, so you would go locally if you were in an emergency. So, and yeah, there's a whole host of issues with that, which I'm sure you're aware of. So yeah, we're getting there. Things have improved, mostly with the national centre. There are still a lot of local issues. There's been a lot of politics. There's been a lot of kickback from more local non-specialist cardiologists who didn't particularly want standards, because it meant things had to go to the specialist and they would have to stop doing certain things. So it's been a really big learning curve for me, and how these things work and how to influence change. So yeah.
Thank you. That's very helpful. I did want to circle back. This is sort of a completely different point of view for Tracy, which is, I'm very aware that we're all women here, and I'm very aware when I look at the registrants that it was predominantly women. So I was curious in terms of your self-help aspects in your book, in terms of the strategies, in terms of acknowledgement. Did you see any patterns in terms of gender, in terms of people's ability to manage their emotions proactively? And I also know the research says that men actually in general are much less compliant, healthcare in general. So I wanted to follow up with you about that, about where did you see gender impacting, or did you, in your interview?
Yeah, sure. Well, first of all, in terms of the book, I think it was definitely harder to reach out and get men's perspective, the perspective of men. That was number one, one thing we really strove for. But in terms of working with folks in my, therapy practice, I really didn't see a big difference. I worked with both women and men, and some of these men were very active and really, following through with strategies. And so I didn't really see any kind of divide in my practice.
Got it. Of course, those were the people in therapy.
Mm-hmm.
So we are at 11:01. There aren't a lot of questions in the box, although I encourage people to look at it, but there is one. So if people can stay for one more minute, I wanted to ask about this and discuss this briefly, which is, we have a question from Bistrzelova, which is essentially, when we talk about mental health in general, we know that in many low resource settings, there's a lot of partnerships. So for example, the WHO has a statement on mental health needs. So what do you see as a potential, and I'm going to start with Layla and Grace, just because I think it's more relevant, to join in and partner with some of the overall conversations? Do you see this as a role for the patient family organizations and the mental health professionals to support just basic provision and awareness of mental health? I know India, for example, has a big initiative around that. So Layla, do you have any thoughts about partnerships and with other diseases in terms of WHO stuff, or are there programs in Pakistan?
Yeah, so with regards to mental health, I think we do have partnerships, not specific to mental health, but generally speaking. So we do have with WHO for sexual and reproductive health, and then cardiology, etc. But one of the major issues in Pakistan and other LMICs is not just the acceptability of this, or not just the implementing or partnership, but we have lack of resources, not in terms of general healthcare system, but specific to mental health expertise. So we have very handful of expertise on mental health, psychologists, psychiatrists, therapists, etc. And that too, they are too expensive. So, so what I've experienced in my clinical practice is like people are not compliant for example, these therapies or maybe coming to these psychologists because it's too expensive. I mean, for one visit is like 4 to 5,000 Pakistani rupees, which is around $25 to $30 for, so it's so an average income here in Pakistan, like above 60% of our population, they fall below the poverty line. So it's very difficult, and we do not have resources like to fund these type of services. People would prefer to spend that amount of money on maybe visiting a cardiologist or maybe a surgeon or maybe some other specialty versus coming to a psychologist. So this compliance is a major issue apart from having the accessibility to these expertise. So I think with regards to partnership, it's very important that we can't have these type of expertise overnight or funding overnight, because the government at the national level, they are least interested in CHD, and they are least interested in spending and investing on mental health. So I think we have to initiate and we have to partner, do the partnership with a lot of NGOs. So we are more than willing to, do the partnership, and maybe some small initiatives. So for example, training healthcare providers, they may not be psychologists, they may not be at that level, but, some of the basic trainings that could be offered to them specific to CHD. And so maybe nurses could play this role. Because we do not have social workers here in our system, but nurses could play this role, midwives could play this role. So we need to come up with some innovative ideas, and we are more than happy to partner to do a partnership with a lot of these NGOs. So maybe Amy, we can have it offline discussion around this.
Great.
Thank you.
Thank you. And Grace, are you seeing, are there activities just in general around, for example, the need for mental health providers that you can imagine your group getting involved with, partnering?
Yes, definitely. But this again is like what Laila says, the whole accessibility issues. There isn't, as to my knowledge, I don't think any of our medical institution actually offer such services for us to see a psychologist. And also the other aspect is like the government, it's like CHD is only because it's not really discussed widely, it's not a very known disease. So, all the attention goes to the diseases that, for the diabetes and the cancer and the kidneys, and so like NGOs are not really, wanting to help CHDs. There's no really much development of CHD. Yeah.
Great. Well, thank you. I think we need to stop there. I really appreciate everybody's time. I will note that if people want to stay a little extra, I will actually be staying. I can stay another 10 minutes or so. So anybody who wants to do that, go ahead. I wanted to just thank you again. That was an extraordinary session, and remind everybody this will be taped. It will be available at the Global Arch website. I want to just give a shout out to Global Alliance for Rheumatic and Congenital Heart Disease, which of course I'm the president of, and ask if there are groups on this webinar who are not members. We hope you will join. Membership is free. We're an alliance of congenital rheumatic heart disease patient family organizations around the world and the groups that support us. And if you are a Global Arch member, but you haven't been that active, we would love to see you back. I think our plan right now is we do have leader forums the first of the month. And we were just discussing before this began that we would like to have an opportunity to have more discussions. So bring some or all of the presenters into one of our leader forums. So do, let us know if you're interested in that. You should also get a notice. So with that, we will say goodbye to our presenters who need to go, and I appreciate probably most of you do. So thank you so much. That was extraordinary. And I'll let people drop off.
Okay.
Thank you, Amy, for hosting.
Thank you so much. It was really great. Thanks.
Yeah.
Thank you, everyone. Bye-bye.
Thank you.
Bye.
For people who are still on, I love the book. Love the book.
It's still not available in Canada, but how
I
do you?
think I
Did you
think it's
get it?
being released in January. I think it's being
Okay.
released in January. I had a sneak preview because they wanted me to potentially write a blurb, and it's great. And I actually think that, so sometimes I thought, are they, spying on my therapy sessions? Because so many things they were talking about are the things that I regularly talk about. The strategies are strategies that I've regularly used. So I think the book is excellent. And I actually see myself recommending it, not just to people with congenital heart disease, but to clinicians, and actually even to people with acquired heart disease, because a lot of the skills are applicable. And I think that just as we sometimes expect our adults with congenital heart disease to access resources made for people with acquired heart disease, sometimes it's okay to go the other way as well. But I loved it. And I'm known as somebody who's like, a critical editor, if you will. The book was phenomenal. It was a joy to read every chapter.
And they were good. They were good about reaching out and being collaborative, which is great.
No, I also wanted to just mention, and then I'm going to allow people to raise their hands, that basically at one point what was said was hasn't been a book published in this, and it sort of made me laugh because I have been on there's been tons of medical journal articles on this.
Mhm.
And this is what there wasn't, is a concrete workbook for people to actual achievable strategies, particularly since we know that most of us are never going to get it from our doctors. Just it's going to continue to be a battle for resource reasons and lots of reasons. So I wanted to encourage, we have 14 attendees still on. If anybody would like to raise their hand and make a comment, I will allow people to answer live since we're now a small group, which may not be true. So I am looking and seeing if anybody's raising their hand. I think, okay, Edward and Paula. Okay, so I'm going to start with Paula, who it will be lovely to hear from. Somebody else who it would be great to see. I'm just trying to see, okay, go ahead. Paula Miller, who is, well, you can introduce yourself. Go for it. You can talk now. Paula, can you, I think I thought I clicked that. There she is. Sorry.
Now, can you hear me?
We can, yes.
Perfect. Great. I had to unmute myself somehow. So hi, everybody. I recognize the three of you and also others that were on the panel. This is great, Amy. I'm glad you all did this. I've been looking forward to seeing it. And I just wanted to say that I was very fortunate also, like Adrian, to be a reviewer of the book, having worked with the peer mentor program way back to when Amy was running it, all the way back to almost the beginning, and have known and worked with Tracy. So I was thrilled when she told me and asked me if I would take a look at it. And I was, because for those of you who are on here who don't know me, I've been with ACHA quite a long time now, and am a patient with tetralogy, an aging patient with tetralogy who has had numerous psychological challenges and maybe PTSD types of experiences over my life, and never got the help I needed. So to have read this and to see that there are ways that I can personally take care of myself as a patient and others are going to benefit from this is phenomenal. I also wanted to speak to the guidelines that Adrian talked about. I think they are also phenomenal and very, very helpful. And to get a chance to sort of take a look at some things that Adrian asked me to look at too. And I feel very fortunate to be in a position to do that, as I know Amy is also, because it for all of us who are patients as well as professionals working in nonprofit organizations, I think we have the opportunity to see a big gamut of how people are responding and reacting and what the needs are. So I just wanted to say, thank you for all of that too, Adrian. It's been very helpful. And that's all I wanted to say. It's great to see everybody's faces. You can't see me, fortunately, because I'm like working from home and not ready for meetings. But Anyway, it's great to see your smiling faces, and you can mute me back. I'm going to have to leave because I do have a meeting in a few minutes, but I've got a few more minutes. I'm going to listen.
Great.
Thank
Thank you.
you.
Thank you so much, Paula. I did want to quickly answer a question that came up in the chat. Somebody asked what Global Arch is, so I just wanted to briefly talk about that. As I said, the Global Alliance for Rheumatic and Congenital Hearts, our mission is transforming lifelong outcomes in congenital rheumatic heart disease through empowering organizations, patient family organizations specifically. As Paula referenced, I led the Adult Congenital Heart Association for 13 years and left 10 years ago. And I think a lot of us talked about the power of patient family organizations, not just, and Liza talked about this, not just to support each other, but to transform policy, standards, all those kinds of things. And we believe that's important worldwide. And that basically you can join as an alliance member, as an organization, but you also can join as a supporter. So, and be involved in our activities. So I hope folks go to our website to do that. The next person I'm going to call on is Edward Callis, who's on the phone. I mean, with us. So let me allow him to talk.
Hi, can you hear me?
Yes.
Yes. First of all, it was lovely to see you guys. It was a pleasure to collaborate with many of you. Well, I had one question for Adrienne in particular. I read the statement with great interest, and I do find that the problem we have is to enact what we already know. So it's great that you made a statement, and it's from a very the scientific group is obviously a very important one. We do have in Italy, for example, guidelines regarding the minimal care. It's called minimal psychological care. And by law, we have to give psychological support in cardiac rehab. This is the only place in which psychological support is obligatory in the hospital where I work. But what I find really difficult is, even though there are guidelines, even though there are laws, even though there are clear scientific evidence, there's clear scientific evidence that psychological support is necessary, I find it very hard to implement these kinds of services, Who will invigilate that they will actually be provided? In different realities, it's so complex. Europe, America, Canada, the other countries, have a whole different situation in which there is more difficulty. So I think the only way forward is somehow to try to include the minutes of assistance in a legal framework. That's the best solution that I found, although obviously it's very complex. So I don't know if you had any comments on this.
I think that, we know that it's possible to do this. So if we look at cancer, for example, so you wouldn't build a world-class cancer center and not include psychosocial oncology. So there is absolutely a precedent for this. We can make it happen if we collectively agree that we want to do this. So, and that's where I said, I do get a bit strong-worded about this. So all along, I've been pretty consistent in that this would be my vote to include this as an essential component of care. I do think we need to have it included as that essential component of care in a lot of different places. And so, accreditation guidelines works well for US. I think it should be, in any country for which it's realistic to offer it now. And I do realize things are very different in lower and middle income or resourced countries. So I realize there are unique challenges in different countries, but in countries in which we can do it, I think we need much better advocacy work. And what I think about advocacy is It's going to be uncomfortable. It's going to be difficult. If it was so easy to do, we wouldn't need advocacy. We'd say, hey, how about this? And everybody would say, great, let's do it. So I think we need as many voices as we can to be strong advocates. I do think we need that partnership between patient and family organizations and clinicians and decision makers at the hospital or local level, because if we talk about philanthropy, when somebody comes and says, hey, I want to donate for this, it's not like a patient organization gets to say, this is where we'd like you to invest your money. It will be heads of programs at fancy dinners having these conversations. So I think we need to work really, really closely with patient and family organization leaders. Clinical and academic and institutional leaders need to do a better job partnering. The other thing I sometimes think, as somebody who does research, it takes forever to formulate a study, do a study, write it up. It's hundreds and hundreds of hours. Imagine if we put a fraction of those hours into actual advocacy work. So I think that we have time. We need to redirect our effort toward knowledge translation. And the one last little thing I'll say is, when we do research on things like, let's say, echo or ventricular assist devices or all of these things, when we do research and when we figure out that there's better ways we can do things, like we can image and we can have better outcomes, or we have this interventions, they don't just sit in academic journals. We actually implement those in the clinic setting. I don't understand why we wouldn't do research into whether it's psychosocial outcomes and or even things like transition, and why we wouldn't implement those in the clinical setting. Otherwise, why bother doing this research if it actually is going to have no impact at the patient level? So this is my advocacy, and I've been pretty consistent about this. I don't know how effective I've been, by the way, but it will continue to be my message.
Thank you, Adrienne. I wanted to just quickly, there's a question I didn't see in the box, which is somebody asked about using anti-anxiety medication in congenital heart patients, whether that is appropriate, not, it's very done. Do you have a brief comment on that?
Yeah, I would say that, so I'm a psychologist, not a psychiatrist, so I don't want to comment too much, but I will say in our statement, we do mention that. So that was one of the advantages of having pediatric and adult psychiatrists, is we actually go through the medications and we have a list of what medications to consider and what are some unique potential physiological notes to mark. So some considerations relevant for congenital heart disease. So, and our paper is freely accessible. So I would feel not comfortable making a direct comment, but we definitely cover that in our statement. And we had really great psychiatrists write that bit.
Great, thank you. And I think our last comment is going to come from our Vice President, Disty Pearson. So Disty. And you're on mute. There we go. Can we see you?
You can see me.
I'm sorry, we can't see you right now. So if you want to turn on your video, go for it.
So I don't think I have that option, but that's okay. But I agree with everything that's been said. And Adrienne, awesome thoughts. I think, in terms of the studies that look at what I refer to as sexy devices, you got to follow the money. There's somebody selling that device, and that's what's driving that. We have to figure out other ways to have the psychological support driven by some kind of money at some level. I must say, I also find it somewhat daunting, particularly in low and middle income countries where having any kind of psychological support at all is a taboo. And then having congenital heart disease and or rheumatic heart disease is a taboo. And then but I do think that having the book, which I've also had a chance to look at, translated into as many languages as possible, that's going to be a key point. And also developing more leaders. I mean, you look at Tracy and you look at Liza and you look at you, Adrienne, and you look at and Amy and Sheila. These are the people that have changed the care. And we just have to take more advocacy, more leaders, and change the care one at a time. It's the only way it ever happens. Thank you for a great talk.
Thank you so much, Disty. And I have to say, I always feel like patient family advocacy organizations are really going to be the leaders, because of course, when you talk about patients' papers, that's what drives people careers. Like the number of times I've been on groups and everybody immediately goes to, let's write a paper and even let's write guidelines. It's like, and then we can publish them. It's like, okay, at the end of the day, the blue fairy is not going to come. The blue fairy is not going to come. The only, and this is true for WHO. It's true for every declaration from the world to the local. You only make things happen if you make it happen. So I'm very honored to be with all of you and know that we've all been working, many of us on this call, for more than 20 years to get this changed. And it can be very frustrating, but I like to see what's happened. We do have a somebody named Carolyn who would like to talk. I do want to note it's 11:23 now, so just do a time check. Adrian, do you need to leave?
I have a couple more minutes I can stay.
Okay, great. I'm going to allow Karen to talk, and it's if you can introduce yourself at the beginning before you say your question, that would be great.
Hi, can you hear me? Okay, my name is Karen Lynn. I'm actually from Kawasaki Disease Canada. So while our patients, our families are not congenital heart disease patients, still the psychosocial aspect is still a huge thing for them, especially for the parents at the beginning and then the children as they get older. So I just wanted to echo or reinforce what you were saying, that I truly believe that the patient organizations are going to play a huge role in this, because especially in our population is such a smaller group. I mean, within the major city center I live in, there's only 50 families currently. And then across Canada, I don't even know the exact number, but it's probably quite low. So for us, we have to rely on the patients for us to band together and provide that support for each other, because unfortunately, there's just not the numbers to get the support elsewhere. So that's what I find. Like, I have my own group on Facebook where I have people from around the world, but we only have each other. So I find that family supporting families is kind of where it's starting. But of course, we need that additional support for things that we can't just manage on our own. That's when we're going to need, professionals to help there. But I just wanted to echo that. I think you're absolutely right that the patient organizations will need to really step up if they want this to happen. So.
Thank you. No, and it's interesting that circles back to the question that was asked about coalitions. That obviously, I mean, Global Arch is rare because we're a coalition of rheumatic and congenital heart disease, which is really funny since our life pathways are virtually identical once you have it. And I would also note that obviously getting more psychosocial support in cardiac programs, and it may even be that in acquired heart disease, I suspect that this is lacking, and these are the kind of alliances we can build. And also, I think, Karen, you talked a little bit about this idea that the word advocacy can be very controversial. People can say, why did you know this problem? But at Global Arch, we would basically say the base of advocacy is learning how to self-advocate, right? That's what you want everybody to do. And then the next level is speaking out. And the next level is, sort of, there's a whole level of getting involved in policy advocacy, sort of thinking about, okay, this is, how am I going to kick it up at the higher, sort of the national level or global level. But when Global Arch started, when we were thinking about it, and a lot of people on this call remembers this, the leaders we talked to in low and middle income countries around the world, and particularly the humanitarian groups, were extremely negative. I can't tell you the number of groups that said to me, oh, you don't understand my patients and families. They have low literacy. They're not going to form groups. They can't form groups, right? Like, you don't understand who they are. And nothing could be further than the truth. I will highlight that these groups are not started by the ordinary person. They're started by a person who has, and I'm very much this kind of person. I was recruited to do this by my medical team 25 years ago because I was told, okay, Amy, you've got a complex thing. You've got education, you've got leisure, you've got money, frankly, to do this, to volunteer. And we've been successful at Global Arch in identifying those people. And that's how it starts. And I just also will note that the world's biggest example of how much patient family advocacy can change is in HIV/AIDS, and is in settings like Uganda, South Africa. So if anybody ever tells you that patients and families can't make a difference in policy, that's completely wrong. It just, congenital and rheumatic heart disease hasn't had an opportunity to be out there in the way we want to be yet. Adrian, do you have any final comments? Disty, I see your hand still up. I'm wondering if you have any final comments, or Sheila, before we end?
For me, just experiences like this, I would say today, are what kind of keep me going, because sometimes it can feel discouraging because progress has been so slow. So I just feel reinvigorated or re-enthused. So thank you very much for hosting this today.
Thank you. Sheila, any last thoughts?
Yeah, I just wanted to say to people who think that, maybe in the developed countries, we're all getting mental health support. We're not. It's not happening here either. In some places, yes, but it's still very rare. So.
Disty, any last comments?
No, I didn't know how to put my hand down. I apologize. But I do think that this group has been amazing. And I think if we can set up something where every few months we get together and have a chat, that will be a great advocacy role for us at Global Arch and for ISAC.
Great. That sounds like a great idea. Thank you so much. So I am going to end now. I hope all of you, if you're not signed up for Global Arch's mailing list, please go to our website. If you Google Global Arch, we'll come up, and sign up so you can get notices about what we do. And thank you and goodbye. This has been exceptional.